Let's begin with the first section of our topic, cancer of the larynx. And in this section, we will talk about the epidemiology and etiology of the laryngeal cancer. Also, the TNM classification and staging and histopathology of the cancer of the larynx. The epidemiology, very important factor, is it's 10 times more common in males as compared to females. But the incidence is increasing as a result of increase in the number of female smokers. So smoking is very important factor leading to the laryngeal cancer. So 10 times more common in males than females. Incidence is increasing in women, and the major contributor is the smoking. Most affected age group is 40 to 70 years of the age. So common in males. Incidence is increasing in females because more and more females are smoking now, increase in the number of smokers, and then the age group in which the cancer of the larynx is present is 40 to 70 years. So it's the disease of the middle and late age, 40 to 70 years of the age. Causes of laryngeal cancer, we have some familial laryngeal malignancy also. So familial factors or genetic factors are present in the development of the cancer of the larynx. Tobacco and alcohol abuse, combination of both. If only tobacco is involved or both tobacco and alcohol is involved, the incidence is increased 15-fold if the combination of both the tobacco and alcohol are present. Previous radiation to neck is also a predisposing factor. Occupational exposure to asbestos, mustard gas, etc. So all these are the factors that contribute to the development of the laryngeal cancer. Now the TNM classification and staging, as we know, is very, very important in the prognosis of the cancer. If it's early stage or it's the late stage, it totally changes the prognosis of the cancer. So TNM classification and staging, and in this T we know already it's the extent of the tumor, how far it's spread or how big is the tumor. So the extent of the tumor is the T, indicate tumor and its extent. Example T1, T2, T3, etc. So all that depending on the extent of the tumor. T1 is usually small, limited, localized. T2 is bigger and things like that. So it keeps on becoming bigger and bigger. So that's the T of the TNM classification. Now N is for the nodal involvement, the spread of the tumor to the node. If there is involvement of the node or if there is no involvement, that's NO, and then we have N1. So that's all the extent of the involvement of the node. Regional lymph node enlargement and its size. Example, we can label it NO, no nodal involvement, N1, N2, and etc. Metastasis, M is indicate distant metastasis, absence of metastasis, MO, and presence is M1. Further grouping into various stages. So that's the T and M classification, which tells us the tumor size and extent, involvement of the lymph node, and metastasis, whether the tumor is metastasized or is not metastasized. Staging now is based on the TNM classification. If it's stage 1, 2, 3, 4, again depend on the TNM classification. Histopathology. Histology, which is the how the tissue under the microscope is appearance of the tissues, which is removed by the biopsy, and how it looks like. That's the histopathology, or the changes in the tissues. Squamous cell carcinoma. Histopathology is it's the squamous cell carcinoma in 90 to 95% of the cases. So 90 to 95% of the cases are squamous cell carcinoma of the larynx. Varied grade of differentiation. Caudal lesions, they are well differentiated. Supraglottic lesions are anaplastic. So again, squamous cell carcinoma is in 90 to 95% of the cases. Different degrees of differentiation are present. If they are the vocal cord lesions, they are well differentiated, but if they involve the supraglottic region above the glottic, they are more anaplastic type of cells. Poorly differentiated cells are present. So this is the histopathological appearance of the tissue. Next, also the remaining, we said 90 to 95% are the squamous cell carcinoma. So if the remaining 5 to 10% are the other type other than the squamous cell. They can be verrucous carcinoma, spindle cell carcinoma, malignant salivary gland tumors, and sarcomas. So these are the different tumors. We have squamous cell 90 to 95%, remaining 5 to 10% we have verrucous spindle cell, malignant salivary gland tumor, and sarcomas. Now, classification of sites and subsites in the larynx. Site, we have a supraglottic. Main larynx is divided into three parts. We have glottic region, supraglottic, and subglottic. So main sites are the supraglottic, glottic, and subglottic. Now they have some subsites also. In the supraglottic region, we have suprahyoid epiglottis, infrahyoid epiglottis, aryepiglottic folds, arytenoids, and then we have ventricular bands. So all these are the subsites of the supraglottic region. Then we have glottis, in which we have true vocal cords including anterior and posterior commissure, and then we have subglottis, which subglottis up to lower border of cricoid cartilage. So all these are the different, we have supraglottis, glottis, and subglottis, and then they have some subsites also. The subglottis is up to the lower border of cricoid cartilage. So that was all about section 1. Thank you for watching sqadia.com.